Program Director of Technology of Radiology and Medical Imaging in Galal University and Lecturer of Diagnostic and Interventional Radiology in Ain Shams University.
Doc, I guess there is some issue with the slides.
Okay. So, to introduce this topic, we have to know that congenital heart disease is the most common congenital malformation and first cause of infant mortality. Fetal echocardiography is a method of choice for visualization of fetal congenital cardiovascular malformation. Next, however, fetal cardiac echocardiography, please, next more than time, okay. Fetal echo basically is done between 18 and 22 weeks gestation and performed in all ultrasound modes, either 2D, 3Ds, M mode, spectral, and continuous wave Doppler. The main issue or main aim for fetal echo is assessment of anatomy of cardiac chambers, atrium, ventricles, great vessels and their connections, blood flow and cardiothoracic ratio and axis, fetal heart rhythm, and finally myocardial performance index. Next. Yet there is some limitation of fetal echocardiography, like it's time consuming, taking between 24 to 6 minutes. Also, it is user dependent and depend on a technical skills and experience of the operator. Also, there is a limitation of acoustic window either by maternal cause or fetal causes. So next, the emerging of a new technique which can complementary help the fetal echo in diagnosis of congenital heart disease, fetal cardiac MRI, giving the advantage as it's has no limitation, either maternal obesity, uterine myoma, twins, or fetal limitation like oligohydramnios, polyhydramnios, fetal abnormal position, and rib calcification. Also, fetal cardiac MRI gives additional information in many topics like cardiac tumor, diverticulum, pericardial cyst, and pericardial effusion. And without doubt, it can detect most of all extracardiac abnormalities. Next. So the aim of our work is to highlight the advantage of MRI over fetal echocardiography in assessment of fetal congenital cardiac abnormality. Okay, next. Our study is aimed at a cross-sectional study. It taking 2 years of duration. It's occurred either fetal cardiac MRI or postnatal echo in Ain Shams University Radiology Department, and the partial source of the cases was from fetal care unit in Ain Shams University and Cairo University. Next. The study population was 52 feti, with inclusion criteria of the mothers of all pregnant female suspected or diagnosis with a fetal congenital cardiac malformation used a fetal during routine antenatal care using fetal echo, and excluding all maternal claustrophobic mother and mothers with cardiac valve replacement therapy or any metallic implants. Okay. There is no special preparation for mother to do either fetal cardiac MRI or fetal ultrasound, either the specific or the detailed history, detailed medical history, detailed family history, detailed any previous pregnancy with any congenital heart disease. Next, obstetric ultrasound and fetal echo occurred with basic all data of obstetric ultrasound using knowing a placental site, amniotic fluid index, and numbers of umbilical cord vessels, basic fetal biometry and fetal Doppler and abnormal situs, followed by fetal echocardiography, including basic and detailed sequences. After that, so we are taking appointment to do an MRI, fetal cardiac MRI, was performed between 24 to 39 weeks gestation, while the mean age of the maternal MRI was 30 weeks. Cases, the mother are asked either to lying in supine position or lateral decubitus, whatever it's relaxing to her, because it will still for more than 30 minutes in this stable position. MRI was performed using a 1.5 Tesla superconducting magnet using a surface torso coil with no maternal or fetal sedation. Control maternal breathing was asked for the mother, and the imaging range between 24 to 45 minutes with the average is 30 minutes. Next. The imaging sequence by sequence at the radiological point of view, starting with a survey, then shifting into maternal planes, axial, coronal, and sagittal to determine fetal position and situs assessment. Then followed by single shot fast spin echo for the fetal body planes, either axial, sagittal, and coronal, directing into cardiac axis using mainly balanced single shot fast spin echo, using black blood images, white blood images, semi-steady state images, and finally we are trying to do a new technique with dynamic single balanced study for functional assessment. Next. The crucial point is that each new acquisition is prescribed by using an image of immediately previous one, because the baby have a continuous moving and it's non-stable. So we are dependent on immediately previous acquisition to avoid misregistration caused by fetal movement. Also, we can find any abnormality in any extra cardiac region. So we adding an additional imaging for this specialized part. Next. This image can summarize how we can getting a perfect acquisition, starting with an axial plane, which is most frequently seen or captured in the MRI, from which we can obtain a sagittal, mid-sagittal plane, from which when choosing aortic arch images or plane, we can getting a coronal plane from it. And we are proceeding to do an long axis view by taking a row between the apex to the mid mitral valve to obtain the long axis view, from which we're getting a 90-degree view for short axis view. And from this short axis view and from the center of left ventricle and right ventricle, concentric and right ventricle crescent shape, obtaining a perfect 4-chamber view, from which we're getting a detailed 2-chamber view, either right or left. Next. So to highlight how the cardiac MRI vision or image, it's appear with side image of a fetal echo. We can see in the axial plane four cardiac chamber, and interventricular septum is central. Cardiac axis is 45-degree. Both atrium and both ventricle have a comparable size. Atrioventricular and great vessels valves are occasionally seen. Next. Also, when getting upwards, we can see a left ventricular outflow tract and outward of aorta at the level of above, or can get a right ventricular outflow tract and bifurcation of the main pulmonary into the right and left main pulmonary. And finally, getting a 3-vessel view, from which aorta wind around the trachea, as well as left brachiocephalic vein seen meet right one to forming a superior vena cava. We can see that the MRI images is similar or complementary to the fetal echo. However, the anatomical structures are more delineated in MRI. Next. In a coronal plane, we can see a cardiac apex, direction of its left ventricle, outflow tract of its, inflow systemic vein, superior vena cava, inferior vena cava into right atrium, and tributaries of this systemic vein, either brachiocephalic vein to joining superior vena cava or hepatic vein drains into inferior vena cava. Next. As we will see on these images, we can see a hepatic vein draining into inferior vena cava, which reaching to right atrium. Also, you can see in a coronal view an outflow tract of the left ventricle. Next. superior vena cava entering the right atrium, and also we can see a mostly delineated left or right main bronchus filled with amniotic fluid, which giving a white intensity in sequences of MRI because it's filled with fluid, which giving a high signal intensity. Next. In sagittal view, we can see also a systemic inflow vein, superior vena cava and inferior vena cava. However, right ventricle and its outflow tract, pulmonary, main pulmonary trunk is morely delineated in sagittal view. Also, aortic arch and its bifurcation is more delineated. Next. Cardiac function assessment sequence, as I said before in imaging sequences, it was a challenge because there is no specific ECG gated for the fetus to get a perfect functional assessment. However, we are using balanced sequences, cine images, with single-shot fast spin echo in an established method of evaluation. However, the beating heart in a moving fetus is more complicated. And the normal fetal heart rate is more than mother. It's reaching to 160 beats per minute, and unpredictable fetal body motions impair imaging quality owing to motion artifact during MRI acquisition in utero. Next. This is a challenging case when getting an endocardium and extracardium, as we do in cardiac MRI functional assessment in adult. We can do it in fetuses and getting these results. However, this result is not purely correct because we are not using an ECG gated protocol. However, it's challenging and it's giving an hope that it will be, and sometimes it will be a real results. Next. Now we can get the functional assessment in the form of a dynamic view in which we can see how the end diastolic volume of the ventricles in short axis and long axis, either in diastole and in systole. It's by visualization of its size. It's informative and giving a provisional view of the function of the heart. It's not a numerical function. It's just a descriptive function. Next. When getting an interpretation of the view, starting with a fetal echo, prenatal fetal echo, we are using a basic segmental approach, starting with a level of the stomach, then getting outward to get the 4-chamber view, and then left ventricular outflow tract, right ventricular outflow tract, and ending with a 3-vessel view, and additional view of a mid-sagittal view to see bicaval and aortic and pulmonary arch. Yet next, the interpretation of the MRI images is using a modified 10-step segmental approach, starting with a visceral atrial situs, where the stomach and where is the inferior vena cava, if there is right or left bronchus, where it is. So we can, from the first point, we can determine the visceral situs and cardiac situs. Cardiac position, where the apex, is it to the left or the mid or the right? Cardiac size, it is around 1/3 or more. Cardiac axis and angle, it's 45 or more. To the midline, cardiac chambers are numbers 3 or 4, arrangements and size of both atrium and ventricle. Next. Regarding ventricular looping, is it D loop or L loop? Inflow veins, vena cava, superior vena cava, inferior vena cava, and is it if they are entering into the right atrium or not? Pulmonary veins, we're getting if there is partial or complete pulmonary venous abnormality, or it's completely draining into the left atrium. Outflow vessels, size, position, and relation to each other. Ventriculo-arterial concordance with passing with left ventricles, showing is it getting aorta, and this is aorta getting an arch, and this arch getting a neck vessel or not. Also in the right ventricle is getting a main trunk of pulmonary, which is arching with no branches and bifurcate in its distal end or not, and ended with a side of the aortic arch, determining by which main bronchus above. Next. To analyze the axial section from inferior to superior, we can see that normal crossing of the origin of the great vessel with the main pulmonary artery crossing above the aortic roots in a sagittal plane with the cardiac arch mostly parallel to the left pulmonary artery. Next. The results, this slide giving a demographic or description of the maternal age. Next. Age and gestational age and delivery of gestational age of the included mother. Next. And this is a basic fetal biometry and umbilical artery Doppler. Next. Regarding fetal parameter, the gender was mostly 2/3 of our male fetuses. Presentation were mostly of cephalic presentation. Amniotic fluid index was normal in 73%. Polyhydramnios in 11.5% and oligohydramnios in 15.4%. Umbilical cord was mostly 3 vessel included. Also, intrauterine fetal deaths was 1/3 of cases experienced intrauterine fetal deaths. Next. Important history parameters that consanguinity was in 42.3%. Previous history of anomaly was 30%. High risk disease like gestational diabetes and hypertension was just 11.5%. Okay. The results, the agreement between the prenatal echo and prenatal fetal cardiac MRI, it was a significant moderate agreement. Both of them are 26 cases are agreed together and 26 cases were not agreed with together. Next, the accuracy and the comparing the postnatal echo with the fetal MRI and echo and fetal cardiac MRI and fetal echo, we can see. Next, to highlight this, also next. Yes, and next. Okay, we can see here that a fetal echo giving us 86% or 86.4% agreement with a postnatal echo, mostly in left hypoplastic and double outer right ventricle. However, MRI giving higher accuracy with a postnatal echo giving 95.5% in most of green highlighted strips, VSD, ASD, AVSD, and apparent cardiomegaly, TGA, right-sided aortic arch and pericardial effusion. However, the rest of these gray highlighted strips are similar accuracy between an MRI and fetal echo. From this slide, we can see that an MRI accuracy is higher than fetal echo, and in discussion, we can see that it is agreed with previously published papers. Next. Extracardiac anomaly detected by fetal MRI was numerable, either cardiac or extracardiac, like you can see a diaphragmatic hernia and its content, omphalocele and its content in 3 cases, delay in CNS development with microphthalmia, exact measurement of skull bony defect in meningeocele versus meningomyelocele and corpus callosum hypoplasia in 2 cases, grading of congenital hydronephrosis and PUJ obstruction in 2 cases, talipus, detection of exact site of focal accreta of placenta, and anterior chest wall defect with liver herniation, as we will see in the illustrated cases in this important case. Next. Okay, illustrated cases. The first case, almost normal. However, its previous anomaly, the baby was hydronephrosis, and everything was good. Next. Echo finding shows a pericardial effusion, relatively hypoplastic right ventricle, solitary 3.4 millimeter VSD, and suspected mitral regurg. Next. And MRI images show mild pericardial effusion with normal pulmonary venous drainage. You can see the MRI can detect another 2.2 millimeter apical muscular VSD. Next. When comparing this both finding with the postnatal, postnatal finding, we can see that it is normal size right ventricle, mild pericardial effusion, 2 muscular VSD, which is going with MRI finding, and it's called resolving myocarditis. Next. This is the second case in which the previous anomaly with marked hydrocephalus and intrauterine fetal death. Also, there is nothing except this abnormal history of the fetus with intrauterine fetal death. Next. Echo shows cardiomegaly, tetralogy of Fallot, severe tricuspid regurg, absent ductus venosus, abnormal venous drainage between umbilical vein and azygous vein, as we will see in the next image. Next. This is abnormal venous drainage between umbilical vein and azygous vein. It is not normally draining into the right atrium. Next. MRI show developing the baby when getting into next 2 weeks, getting severe hydrops, cardiomegaly, moderate pericardial effusion, single large inlet VSD with common atrial trunk type 2 with side origin of hypoplastic pulmonary artery, with prominent posterior azygous vein with compressed subdiaphragmatic umbilical vein draining into it. Next, however, this baby was unfortunately intrauterine fetal death. Next. Yet this excluding this is not an tetralogy of Fallot. Okay, case 3. This case was 38 years of age and only have a 2-vessel or single umbilical artery in fetal routine antenatal care. Next. The echocardiography shows complete unbalanced AVSD, hypoplastic left side, dilated mean pulmonary artery and pulmonary regurg with tricuspid regurg and aortic stenosis. Next. MRI can see that the heart is cardiomegalic, hypoplastic left side, large membranous VSD, overriding hypoplastic aorta, atretic mitral valve. Next pictures, thickened tricuspid valve, normal pulmonary venous drainage to the small left atrium. Next. Postnatal echo shows it is a case of hypoplastic left heart syndrome with mitral valve atresia, keeping with accuracy of MRI finding. Next. The case 4. The baby, it is a primary gravita with in vitro fertilization with anything was good. Okay. Echo shows double outer right ventricle versus it was a query case. Either it is double outer right ventricle versus hypoplastic left ventricle with large VSD 7 millimeter, interruption of small aortic arch versus coarctation at the level of subclavian artery. It was query either in 4-chamber view or in outlet view. It was a query case by echo. MRI shows it is on hypoplastic left-sided heart, large VSD, hypoplastic aortic arch with interruption at the level of left subclavian artery with normal pulmonary venous drainage. Next. And the postnatal echo shows it is hypoplastic left heart syndrome and type B interrupted aortic arch, exactly as an MRI said. Next. This last 2 cases was very challenging cases and very reported cases. One of them, it was a 24 years primary gravita with in vitro fertilization. Fetal echo revealed mesocardia ectopia cordis. Requested to do a cardiac MRI, revealed an associated diaphragmatic hernia, anterior chest wall defect, liver herniation through omphalocele, positional ectopia cordis of the left ventricular apex with small size main pulmonary artery and agenesis of left pulmonary artery with interatrial septal defects. So we can see that an MRI giving a huge information more than fetal echo, especially in this case of very minute or very small abnormality or defects. Next. Case 6, case 5 and case 6, both of them are experiencing intrauterine fetal death. So we can see it's their postnatal echo. This last case was 34 years old female with echo revealed pulmonary hypoplasia with generalized hydrops and large well-defined echogenic mass 5 to 5 centimeter emerging from left ventricular wall with secondary tachyarrhythmia. Either it is cardiac fibroma versus rhabdomyoma directed into the cardiac MRI, which is revealed a detailed mass size, origin with signal intensity and its component of its mass and septation, confirming it is an rhabdomyoma, it's not a fibroma, with residual mitral valve size and bilateral hydrocele. Next. To discuss these results with a previous mentioned or previously published cases, our study getting a 61% agreement between the fetal value of fetal cardiac MRI with fetal echocardiography. However, Zoo et al. Giving it is an 18% of acceptance. Next. Comparing with fetal cardiac MRI and postnatal echo, our study and Tavares de Sousa et al. Giving a significant agreement and full agreement between MRI and gold standard postnatal echo. Next. Regarding accuracy of our result of fetal MRI versus prenatal echo, we can see that fetal MRI was superior to the fetal echo in comparison to the postnatal echo, with percentage of 95% to 86%. However, Dong et al. Giving also the fetal MRIs is higher than routine fetal echo obstetric ultrasound with a similar higher accuracy of fetal MRI than our study. Next. To get to conclude our study and our aim is MRI imaging as an adjunct to fetal echocardiography may provide valuable information